why should you monitor myotonic dystrophy? I keep being asked this. So patients are diagnosed with myotonic dystrophy and they don't see any medical teams for years. And the question is that right or is that not right? And my feeling is that's not right. And of course, I'll try and go through with you what steps we can take to monitor the complications of myotonic dystrophy, even though we can't actually genetically alter the course of the disease, and the impact that that can have on your lives as patients. And what I'll do as I go along is I'll try and link in to where there's an opportunity in the day where you might be able to talk about that subject with one of our professionals. So hopefully that'll link in. This will give an overarching view of the complex nature of myotonic dystrophy and how we do need to monitor the problems. So these are some of the old photographs. I show these just out of historical interest. You can see this. This is one of the very first Victorian photographs of a patient with myotonic dystrophy. And this is a drawing by a famous artist, a medical artist of myotonic dystrophy. And as you know, there's type 1, there's type 2, and I welcome patients and carers with myotonic dystrophy type 2 today, who I know sometimes feel that they're in the minority, but you're also very welcome today. And a lot of what I say does apply more to patients with myotonic dystrophy type 1, but equally it probably does to a limited degree apply to patients with myotonic dystrophy type 2 as well. I guess that's a good starting point for our discussions. Now, we call it a rare disease, an orphan disease, but actually I don't think we should ever forget that myotonic dystrophy type 1 at least is the commonest adult muscular dystrophy. I don't think we should be under any illusion that this is the commonest form of muscular dystrophy. Not only that, there's all the other problems that occur in myotonic dystrophy, but actually just in itself, it's the commonest form of muscular dystrophy. Unfortunately, this slide is slightly medicalized, but you can see in relationship to multiple sclerosis, it's about 1/10 as common as multiple sclerosis, and I'm sure you've all heard of multiple sclerosis, but for genetic disease, that is quite common. And this is the sad fact. I always show this slide because I think we've always got to remind ourselves of this in our motivations of why we need to monitor patients with myotonic dystrophy and why we need to make every effort to improve that monitoring and improve genetic treatments. And sadly, patients with myotonic dystrophy pass away on average at the age of 53. That's taking all cases, and I see patients from the day they're born to patients in their 70s with myotonic dystrophy. But if you take on average the complications of myotonic dystrophy, I think without monitoring, lead to this type of statistic, that the average age of death is 53. And I think we can do something about that. And what are those complications from? This is a slide showing highlighting the details of a study conducted in Quebec, which you may know has a very high instance of myotonic dystrophy there for various reasons. And they did a very good study there over 10 years, and they looked at what causes these early problems. Why do patients pass away at a young age? And the bottom line is, it's problems with the breathing and problems with the heart. So that then alerts us to how we can try and stop these premature problems. So the question is there any management? You have a genetic diagnosis. If you're lucky, you go home and that's it. And clearly there is a lot of management. You don't have to read this, but this is how complex it is for doctors. They've got to think of at least 11 different aspects of the disease. The heart, the lungs, confirming the genetic diagnosis, the sleep, the cognitive aspects, cataracts, diabetes, sleepiness, the list goes on. So it's a very complex multi-system disease, myotonic dystrophy type 1 and 2, and there's many aspects. So what I'm going to go through is some type of protocol, some type of logical process of how you screen myotonic dystrophy and how that will potentially help. Well, many of you will recognize the picture on your left here, which of course is Watson and Crick discovering the double helix. I think this is the first thing to be aware of. I'm still seeing patients who are diagnosed clinically with myotonic dystrophy who never had genetic confirmation. And I think it's vital that you have genetic confirmation and simple blood tests. And the reasons for that are, one, in terms of family planning, deciding how it may affect your relatives. And so I often see patients who have siblings and cousins who are also affected by myotonic dystrophy who never knew they had it and may, of course, run into problems that could have been prevented. So contact tracing and tracing patients is vital. Of course, at the other end of the spectrum, when genetic treatments become available, we need to know what type of myotonic dystrophy you've got and that you do have myotonic dystrophy. There are some rarer problems which can cause problems with that stiffness that aren't myotonic dystrophy. I've also labeled these things epigenetic factors, somatic instabilities. So these are sort of medical jargon for saying that actually, why do some patients with the same mutation in myotonic dystrophy have problems with the heart and the hands, and other patients might have problems just with foot drop? And yet they've apparently got the same mutation. And that's because the rest of the DNA, how that mutation manifests it in all of you, will be different depending on your other genes. And we're starting to work out with people like Darren Monkton in Glasgow, who you heard Robert talk about, work out what are these other genes that influence how you express your myotonic dystrophy. And almost certainly they're going to be important in terms of developing treatments in the future. Number two, we need to monitor the heart. Remember that statistic about why patients with myotonic dystrophy run into problems. And the irony in myotonic dystrophy, given that it's a muscle disease, you'd expect it to be a pump problem, a muscle problem, but it's not. It's the wiring of the heart. And therefore, a lot of us suggests that as a minimum, all patients should be having an ECG once a year. But that really is a minimum. And whether more invasive studies on the heart, and some of you in the audience I can see who are under my care have already been through those and may talk to other patients and families, had an EPS study, an electrophysiological study, which is a bit like an amp meter. You put some wires in the vein in the groin and actually measure the electricity inside the heart in real time. And that may be able to predict which patients need pacemakers and defibrillators and which patients don't. And we're still working on that, and there's various studies going on around that. And there are studies, there's a big North American cohort study that was published recently which re-emphasized this. Those that you like academic journals and the New England Journal of Medicine emphasizing the point. And this is a study, you don't have to read all this, it's just to show you that things are happening and people are studying these things. In 2012, a French group looked at, if we did these invasive tests on the heart, is that better for you than if we don't, if we just do ECGs? And it was difficult science, let's just put it that way, but the conclusion was from his group that the electrical test does make a benefit. The problem is, and you saw that list of things we have to do, what I want you to do, if you can see it, it may be difficult, is to look at that line going up there and this line down here. What that shows is that patients who have the electrical tests don't pass away from complications of the heart. But the problem is, if you then come over to this graph here, and these two lines here both run parallel to each other, other problems kick in. So this tells us that it's necessary to look after the heart, but it's not just sufficient. We need to look after the whole patient and not just the heart to prevent these early problems from happening. Hello?
You say this invasive one. There is another one, and it's a jacket that can be done. Are you invested in that?
I'll be honest with you, not at the moment. I don't know much about the jacket technology and detection, but a jacket in terms of measuring the heart electricity.
Yeah.
Well, perhaps there's one of the other specialists. Mark, have you heard of the jacket monitoring system?
No, I haven't. I mean, all I know about is whether or not it's the one where you use somated ECGs. But I don't know. I haven't heard of it called a jacket. Sorry.
I must admit, I'm not completely familiar. Can we come back to that? Because I'll show you what I'm proposing is probably a way to monitor things. A little bit more invasive than the jacket, but not too much more, is this. So at the last time, for those who came up to Nottingham when I spoke and gave a very similar talk to the MDSG's conference there, I showed this slide and I said by autumn, Christmas, this would all be happening, we'd be in placing these monitors. Now if you have a look at these little things here, for those of you that use computers, you'll probably see that you have a memory stick. So this is called a reveal device, and it's the size of those memory sticks. So it's about this big. Now, you could put that under the collarbone here, and it could monitor the heart for any abnormal electrical activity. There were problems with it. I think that's the long and short of it. So now, of course, the technology is modernized. You can see the new one here. So it's the size of a paper clip. Those of you who've seen hormonal implants for contraception, you can basically insert it with a trocar like that, just under the skin. It may not even require any stitches. And this is probably going to be the modern way which I think we're going to be monitoring the heart, not just in myotonic dystrophy, but in other muscular and cardiological conditions as well. It stays, it's limited by battery life, so I think we may have had this conversation, that battery life is actually the key to these, and getting a small enough, powerful enough battery that lasts long enough is the rate limiting step. And this will probably last between 4 and 6 years. But it's so small and it's inserted relatively easily that it may be that just as the hormonal implant, you can have it taken in and every 5 years you'd have it put in. We may have to stratify and decide which patients at risk and only do it in those patients, but I suspect there's going to be a learning curve. And at the moment, we're in negotiation with a company about providing us with free ones of these. They cost lots of money. And so there's a bit of jiggery-pokery going on, if I was to say that, and there is a bit of a delay, but I'm sure that we will be inserting these at some point, I'm not going to say when now, into patients with myotonic dystrophy, at least offering it. I think this is the future from my perspective. And this links into your telephone and actually phones indirectly through the wires without you knowing it. If there's any abnormality that strikes up in this, that's detected by this, without you knowing about it. And the first you'll know about it is you'll get a call saying, well, perhaps we should have a chat. So this is the way technology is going. Now, this is an area which I've tried to invest. So from the heart perspective, I'm doing a workshop on the heart, but I'd encourage you, there are lots of other good workshops this afternoon, and I encourage you to go to those. And one of those is given by Tanika and Sam, 2 of our new neuromuscular complex care centre nurses, who are incredibly experienced in these breathing machines, in non-invasive ventilation. We've come a long way from the whole body breathing machines, and now there's ones that cover the face, cover the nose, and just sit under the nose. And it's a real problem in myotonic dystrophy is that we detect patients who need breathing support, but for reasons we don't fully understand, patients don't tolerate it and don't perceive any benefit from it. I think if patients, and we don't understand that. So we really need to work hard on that. So there's a workshop this afternoon about breathing, and you get to play with the machine. The rep from the company who make them's here today. So go and have a look at them. If you've had problems, go and talk. If you've already tried and abandoned it, go and have a chat in the workshop with our nurses. This is what the companies would like to think it's all about. Nice, clean cut, easy, nasal pillow, they call it, like you're having a good night's sleep, but many of you will know the reality of non-invasive ventilation. It's a difficult field, and I think we need to work on it. So I put this slide in number 4. I haven't actually got any workshops about endocrinology. It probably is important, the glands and how they function in myotonic dystrophy. All I should say is that diabetes is probably slightly overplayed in its prominence, and actually a lot of GPs will know that myotonic dystrophy is associated with diabetes, but will not know the important stuff. And what I want to do is get the important stuff over to GPs. It is important that you have it measured, and actually there's probably other endocrine organs, such as the thyroid, that don't work properly. Cataracts, many of you are good at looking after your cataracts. It's probably one of the best parts of management of myotonic dystrophy because it's such an obvious thing to try and sort out. My plug here is to Dr. Jeremy Rhodes, who often comes to the conference, who's doing work on the cataracts in myotonic dystrophy in East Anglia. I posted his email address there. I hope he doesn't mind. If you're thinking of having a cataract, do contact him. He's always looking for cataract material. I'm sure you won't need it once you've got your new prosthesis in, so do contact Jeremy. We can provide you with that email. So this is another very complex area, and is orthotics. And it's about having the right orthotics person and physiotherapists with good experience. And today, we've got 2 excellent physiotherapists who, and there's a workshop around orthotics, and hopefully they'll be able to give a real-time demonstration with some of the orthotics which we use in myotonic dystrophy and give you their expertise. Number 7, we're racing through the things we should do. I won't look up and see how many people are asleep at the moment. Hopefully not too many. But there's lots of questions about modafinil. And I think those questions are justified, but particularly Dr. David Hilton-Jones, who's kindly here today, is running a workshop on this and is talking about it. It's a part of life with myotonic dystrophy that really impacts on carers' lives as much as the patients'. And there are some things we can do, and they can be very beneficial. This is another area. So Karen Doy from the UCL pre-implantation unit. So starting a family. How many of you heard of pre-implantation genetic diagnosis? Is any? Okay, good. So the word's getting out. So Karen Doy's here and doing a workshop to talking about how you can affect, you can plan for your family in the future.
That's how this works. It's got to encourage people if they'd like to sit. The seats there. There's a way around, isn't there?
Those who can, would you like to sort of move to the corner there so that?
Chris, if you don't mind, if we come around this way.
Yep, you're very welcome to come this way, even during my talk. Come on, don't be shy. So we've got Dr. Mark Roberts talking about the bowels, often a subject which troubles you but doesn't get troubled to the doctor. And both whether it's swallowing or cramps or diarrhea, constipation, accidents, that whole spectrum that we don't talk about, unfortunately, is a big problem in myotonic dystrophy. And there are things that we can offer to help those. And increasingly, I'm offering patients for their nutrition access to feed via a tube in the tummy, which appears to be working well so far, which is something called a PEG or a RIG, something that hasn't really been talked about in myotonic dystrophy, to cope with the swallowing problems. And of course, this links into the problems with the chest infections, the single biggest cause of problems that in myotonic dystrophy. We won't go through the cartoons, we don't need to emphasize those. The myotonia, you can see it can affect your tongue, it can affect your hands, it can affect your swallowing, it can affect lots of things. Patients with muscle pain, David Hilton-Jones and Mark Rogers and others may have their own perspective on it. I think it's worth a go with mexiletine. I think some of those aches and pains that are non-specific may respond to mexiletine.
I was told I couldn't have that drug because of the pacemaker I had fitted. They were going to do that for the pain in my legs. They said you can't have that because of the pacemaker.
Well, mexiletine can have a problem, an effect on the heart. It can lengthen something called the QTC. And as long as that's monitored, it shouldn't be an issue. It's about having, I think, professionals who are used to and familiar with using these drugs in the right context. So that's why we're trying to educate. I go and talk to other neurologists about myotonic dystrophy to tell them that we can use mexiletine. And there has been a study recently produced by Rochester in North America to show its safety over at least 6 weeks. So I think we can use mexiletine more in myotonic dystrophy, and that's something that needs to be discussed for the myotonia. Care cards, Margaret's heavily involved those. I'm sure Margaret will tell you about the care cards. You should all try and carry one. And finally, just to say, because I think we're running out of time, and I want to try and catch up on some time, is the patient registry. So this is run out of Newcastle by Hans Lockmuller and Libby Wood, and it's a sign of the times that they can't make it today because they've got a meeting for the trial Optimistic. So they're juggling so many things. There's 2 things on the myotonic dystrophy calendar, but they send their best wishes. And I'm involved as well, and thank you for those who have signed up to the registry. Almost certainly those who are registered will have access to clinical trials more easily, and already there's been 3 clinical trials that have been trying to access patients to date, and I think it's been going for a couple of years now, and there's over 400 patients on the registry. You can do a paper form for those of you who are not keen on computers, but if you can do it online or get someone to help you do with the online forms, that would be better. And it's very easy, and it puts the weight of the effort on the doctor rather than the patient, which is not always a good thing. This is some of the details. It mentions the 2 studies, the Optimistic study and Dr. Sam's study, which have recruited from the registry already, and Libby Wood's details, and we can provide those for you from Newcastle. So I just want to give a plug for a new venture which we started at the National at Queen Square, which is a 6-bedded ward, which you'll see here on the left. Actually, I think it was Dafford who actually took that photo, did you say? It's not like an acute ward, it's an elective ward, and it's not just for patients with myotonic dystrophy, although I have to say lots of patients with myotonic dystrophy are coming to it because it's very appropriate for them. And the nature of the ward, and if I was to be honest, we're still developing the idea, is that you have all your care, all that monitoring, everything that we've said, done in one episode, probably with a couple of nights stay. It's very nice, it's modern, it's clean. There's a PlayStation for those of you that are into PlayStations. There's iPads. Hospitals can get a bit dull, can't they? So the idea is that over a couple of nights, you see the cardiologist, you see the dietitian, you see the speech and language therapists, and it's called a complex care centre, and it is for patients with neuromuscular disease, and I think it really is very specifically favourable and appropriate for patients with myotonic dystrophy type 1. And this is Sir Robert Francis. Anybody recognise Sir Robert Francis? So he goes around hacking and slashing through the NHS, cutting out all the, let's call it the dead wood. He's a lawyer. But he accepted our invitation to come and open the centre because he said it was the first time we've been asked to actually open something rather than close something. So that's Sir Robert Francis, and this is Dr. Quinn-Liven on the left. Some of you may know Dr. Quinn-Liven from paediatric days, but she's come to join us at Queen Square from Oswestry, and she's a good link between the paediatric and adult side. And this is just to say some other things we're trying to do. We're trying to set up a standards of care. In other words, guidelines that are then taken, and this is something we've published, that we take to the government, we take to the commissioners and say, look, this isn't happening throughout the country. You need to put more resources. And it gives some political leverage to make that happen. And this is something we're developing. It's a bigger project than we all anticipated. So health screening in myotonic dystrophy shouldn't be this. This is Louise Spiegel, my nurse specialist, and me. We shouldn't be waiting there with spiders hanging off us, waiting for the next patient, saying, where are they? It should be an active, dynamic process. There should always be something to do, something to try and improve the many, many symptoms which I know a lot of you experience. And the final positive note, this is a press release from June from a pharmaceutical company called ICIS, based in California. And they've been funded by a big pharmaceutical company called Biogen to test a form of genetic treatment called antisense treatment. It's not that it doesn't make sense. Antisense means it binds to the abnormal piece of myotonic dystrophy mutant mRNA, the thing that leads to the protein, and takes it away. So it dissolves those aggregates in the nucleus that cause the problem in myotonic dystrophy. And this is entering phase 1 trials. Unfortunately, it's not open to us at the moment, but we're in contact with the doctors. They know our registry exists, and when it goes to further studies, they almost certainly want to make it international, and that will include the UK. So that is a sort of ending on a sort of note of optimism in terms of treating the fundamentals of myotonic dystrophy and not just screening. Thank you very much.